you again for inviting me. And today I wanted to give a little bit of definition of what is perinatal palliative care, because it has a prenatal and neonatal component. And also, I would like to present a little bit the program that I initiated about 15 years ago in my hospital with these clinical, educational, and research activities. And I also want to underline that in order to provide perinatal palliative care, you don't need to have a big team like I have at this point, but it's just about a mindset that each perinatologist should have in the care of families expecting babies and babies with life-limiting conditions. Okay, so the American College of Obstetrics and Gynecology published in 2019 an opinion document that states that perinatal palliative care is one of the options to be offered to women expecting babies with life-limiting conditions, and this document has been endorsed by the American Academy of Paediatrics as well. So the ACOG, so the American Association of Obstetrics and Gynecology, underlines that the perinatal palliative care is focused on achieving quality of life and comfort for the babies and to provide support to families respecting their cultural beliefs and their values. And so we have a two component, a prenatal component, which is defined as a plan of care offered again to women who elect to continue their pregnancy when they have a fetal diagnosis of life-limiting, of life-threatening condition. And so this prenatal component is supportive for the mother, for the family, and wants to prepare a plan of care for the baby to come. And then the neonatal component includes medical care of the infant based on the diagnosis, the prognosis, the family preference, the family background. And there are different plans of care. It could be end-of-life care, it could be supportive palliative care, etc. So I started this program about 15 years ago, and our mission is to honor the life of babies with these terrible, terrible diseases by offering interdisciplinary intervention. And we are also committed in teaching and research to fulfill our vision. And our vision is that our model of care will become the standard of care around the world. So our program is a service at Columbia University and includes a team. You see the picture here. I am the medical director, and currently I have dedicated professionals, specifically 2 nurses, a social worker, and a manager. And then I had other collaborators in the NICU. You see their names on the side, who help us taking care of these mothers and babies. We also have collaborators, champions among the obstetrician maternal fetal medicine groups, and here you see picture of some doctors and nurses helping us. Let's talk about our what we call the perinatal journey. So how do we accompany these families during pregnancy? First of all, I want to share with you a little bit the population that we serve. In 2022, we met 59 pregnant women. We had 160 encounters prenatally with these mommy and families. And when you include the moment of delivery and the postnatal follow-up and the bereavement support, we had around 700 encounters. So it's a lot of work for our team. And here you see the diagnosis. We have babies with trisomy 13 and 18. We have babies with very severe brain disease, very severe cardiac condition, baby whose kidney are missing, so renal agenesis, and many others. We also took care of babies born too early to be saved. So those that are born at or less of 22 weeks gestational age when they're born alive, of course. About 1/4 of these patients had their pregnancies and in fetal demise. we then followed 28 infants with comfort care, and most of them, they died within the first few days of life. However, some of them were discharged home with hospice support, and some of them are still alive. Our team was also able to follow some babies who ended up in intensive care, but offering a sort of palliative care supportive, no? Although they have been treated in intensive care with full support. Here are the steps of the journey. So our obstetrician introduced us to a family who had a fetal diagnosis of life-limiting condition, and we meet with them. We discuss the medical part, so how the baby will look like when it's born, which are the problems of this baby, etc. I want to hear from the family what is important to them, what they want to do during delivery, etc. And so myself, along with my team, can put together a birthing plan. Now, this birthing plan, let's say the outcome of this discussion is documented in the medical record chart of the mommy. So then anybody in the hospital, when this mommy will come for delivery, will know what the plan is, and they will respect and welcome the plan decided by the family with us. Now, when the baby is born, if I am around in the delivery room, like today, for example, the case that I just have right now, I'll be happy to be there, especially to mentor my fellow, the young doctor working with me. But again, as I said, since the plan of care is written in the medical record chart of the mom, every doctor will follow our suggestion. And of course, we focus on bonding and on comfort for the baby. And in fact, if a baby survives the delivery room time, will not come to the NICU, but will go to the postpartum with mommy. And I have to say that the work of our team brought about an important culture change from, let's say, NICU admission, which is very problematic for bonding, versus a postpartum limitless bonding. You can see in the difference in these two pictures. In one, the baby's in the isolate, in incubator, in the NICU. On the other one, baby is surrounded by family. And we are present in a discreet fashion, make sure that the baby is comfortable. Now, which are the pillars of comfort care? The baby should bond with the family freely. The baby should be nice and warm. The baby should not be in a situation of hunger or thirst, and of course, should not be in pain. And this seems to be easy things, but sometimes are a little tough to achieve. And so I'll give you some pictures now to show how this is done. So bonding is important, and imagine that you have a mom who needs to go for C-section. So in that case, we do a cheek-to-cheek, mommy and baby, and the daddy is on the side, sit down on the side of mommy in the operating room. So then there is a first bonding directly in the operating room, and then eventually the baby who will go in recovery room. We usually use a private recovery room where mom, baby, and family members can enjoy the baby and, for example, blessed, baptized, pray for the baby, or taking picture, or do activities for memories. Now, those are other pictures of babies in delivery room or postpartum. In the one on the left, there is, I don't know if you can see, but there is a little baby in mommy's shirt. This is a tiny, tiny premature baby with trisomy 18, who had also a very severe heart condition. And so she lived for 12 hours, basically skin to skin with mommy. The other one on the right is a bigger baby, but again, skin to skin allow both bonding and maintenance of body temperature. Fathers can do also skin to skin, as you can see in this picture. Feeding is one of the few pleasures for babies, even when their life is short. And so we feed our babies. We want to also respect their natural life. We can feed them with a bottle, with a syringe. If they're able, they can breastfeed, but most often they can't do that because they're too weak. or we feed them with the help of devices suggested by our lactation consultant or speech pathologist. And so the goal, because they have a short life, the goal is not to make them grow or reach a certain number of calories, but we want to nourish them to avoid hunger, thirst, and dehydration. And so we're looking for a balance in between comfort and safety as well. We don't want to choke them necessarily. We also have pain scores to make sure they're not suffering. And so we follow this pain score. And we do have plenty of medication. I always tell the parents of the family I meet that no baby should ever die with pain, because we have, as you can see in the slides on the left, a lot of non-pharmacological strategies. And most of the time, those babies are very happy just with those strategies. However, we have many, many medication, painkillers, as you can see on the right. And those painkillers can be given orally or intranasally. And so there is no reason to put any IV to do anything aggressive or invasive to these babies. Now, our team also helps a little bit in the NICU, in the Neonatal Intensive Care Unit, sometimes to help with redirection of care. And this is an example that I share with you. Those are twins. And the one on the right, the small one, was diagnosed perinatally with renal agenesis. The parents could not believe, and they really wanted to double check afterwards, after the baby was born. And so what we did, and both babies are on respiratory support, as you can see here with the nasal prongs, because both of them were born premature. But the one on the right, you can see, is is much smaller than the sister. And we did renal ultrasound right away. We confirmed the diagnosis of renal agenesis, meaning she missed both kidneys. And at that point, the family acknowledged, and the baby died a few hours later because she went to respiratory arrest, as expected on babies with renal agenesis. Now, some parents change their mind along the course. And so this little cute girl here in the picture was born with trisomy 18, and she had coarctation and a large VSD, so a big hole in between the ventricles. The family wanted to do open heart surgery to have a precious time with her at home. Because if we didn't do cardiac surgery, the baby would die pretty much in the first few days of life. And so our hospital is open to operate on babies even with trisomy 18 and 13, if if the parents desire so, and the baby is strong enough to undergo the operation. So we did that. Baby went home, but she kept having respiratory crisis. Babies with trisomy 18, they are very weak, and they tend to have a lot of respiratory crisis, even for common colds or things like this. And so basically, this poor baby was back and forth from the hospital. And every time she came, she needed to be placed in life support. And so it was a tough life. And so the parents at that point, they said, listen, now we understand why you wanted us to do palliative care. This is not life. We don't want to have a baby attached to a machine through the life. And so they decided to switch the care of the baby to palliative care, and she died at home with hospice care at 4 months of life. This is a case which is similar to the previous one, but is quite the opposite. She also was born with trisomy 18, but she basically, she was pretty much okay. And her heart condition was is called PDA, so she had like an extra vessels that needed to be closed at a certain point in her life. But basically, after the closure of this big vessel in close to her heart, which it didn't require actually open heart surgery, it was just a simple closure of a vessel, she actually did very well. She had no longer episodes of respiratory crisis, and right now she's 9 years old. And she has a limitation in her neurological development, as expecting on babies with trisomy 18, but she has a happy life, happy parents, and so we were happy to support her through her life. And the last case is a happy case, and this case wants to demonstrate that we do support our families no matter what. If you know, their story ended up in the end of life for baby, we stay with them. But sometimes we have a happy conclusion. And so these two, you see, there are two families here, two moms and two dads. Both of them, they had premature rupture membranes at 15 weeks during the pregnancy. And so we met the family because when you break your membrane so early in pregnancy, the baby, they are born rightly after. And so we will offer comfort care, of course, because the babies will be too small to do any resuscitation. The story is that those two moms were able to keep the baby in up to 34 weeks gestational age. And the babies were born a few days apart. So they had the whole pregnancy in the hospital all together. And being born at 34 weeks, they actually made it well. And right now, I want to say they're 3 years old and they're doing very, very well. And so we kept doing our follow-up with them. And, you know, we are congratulating with them about this nice outcome. We did guidelines, we published them, and our hospital established a policy following our recommendation. Just to say that that's a big step, an important step. Now, I want to give you a couple of words about some research projects that we completed, some educational initiatives, because as I mentioned before, you know, we have a great team in our hospital. We meet many, many parents, but our goal is that all over the world, other professionals can practice the same and help families and babies in the same way. So we are very strong in research and education. So those of you who are medicine know that there are plenty of studies related to the efficacy of pain management, but there are no scores to assess comfort. And so after a few years of activity of our team, we decided to measure the efficacy of our interventions, assessing comfort through the eyes of a parent. And so this study, we offer to parents anonymous questionnaires that they need to fill up some questions related to the comfort of their baby. We had 24 questions that explored the environment where the comfort care was done, the care of the professionals, the parents' opportunity to connect and bond with the baby, and overall the perception of the comfort of their baby as we were trying to fulfill the baby's basic needs. And you can see that the mean answer here, we had a very high score on the upper part of this table, where high score means more comfort, and we had very low mean scores at the bottom of the table for items where low score means more comfort. We also asked participants to answer this question: could you describe comfort care with a metaphor or an image? And here you can read, we have some little piece of some very, very beautiful narratives. And, you know, I want to underline that these narratives are written by parents whose baby died. And so I'm amazed at how the prevailing sentiments here are peace, calmness, protection, healing, love. And it means that really the care of a perinatal palliative team help them. Now, a couple of years ago, we also published on the Journal of Pediatrics 10-year experience of perinatal counseling and neonatal palliative care provided to neonates with severe and complex congenital heart disease. In particular, we focus on 29 newborns with single ventricle. So those babies, in order to survive, needed to undergo 3 open-heart surgery and eventually, very often, a transplant. And so in our hospital, we have a very, very good outcome long term, but also some of these babies will die along the way, and three open heart surgery and transplant is not an option that is available for many parents. Is too much, and so we give the option to do comfort care. We were very surprised that 13.5% of the families actually opted for palliative care, judged that going through all these surgeries and with no guarantee of survival, 100%, was not an option for them. And so we think that when the medical and surgical condition is so complicated, we still have to respect the desire of parents to maybe have a maybe shorter but more beautiful life than to go through so much pain and suffering. We also demonstrated the benefit of early palliative care. As you know, you can imagine, if you have a personal experience, being parents of an extremely ill infant in the NICU can be very stressful. And so we developed a model of early palliative care called BACI. BACI in Italian means kisses, and BACI here stays for Baby Attachment Comfort Intervention. And so this was a prospective study aimed to assess the stress of parents of infant admitted in our cardiac NICU. So this is not about babies who are going to die. Yes, some of them died maybe because of the cardiac surgery, but we want to measure stress of parents when there is a team who is supporting the family going through the hard journey. So what we did, the method includes 4 domains. Bonding, so then the team nurse will help the parents, no matter how the baby is, sick or not sick, to do skin to skin, to position the baby, to encourage family to change diapers, measuring temperature, feeding the baby, sponge bathing, etc. Feeding was facilitated by the speech pathologist, so we had babies who were very, very sick, colostrum care. In others, they could eat something, etc. Then our child life helped with memories. And lastly, our social worker, our psychologist, and our chaplain provide emotional, psychological, and spiritual support. So these families were really embraced through this method in a lot of supportive what is the result is that we had 77 parents participating, some control and some intervention. And so you notice that families who receive the interventions had much less stress at the moment of discharge. And so this method shows how the early palliative care intervention can really benefit parents and embrace them and support them through this difficult journey. They keep calling me. Okay. Okay. Another important point is education, as I mentioned before, because we want to spread this through the world. So we completed in September our annual 3-day intensive training course. We had more than 200 participants from 34 states here in the United States and from 18 countries all over the world. And you can see the list of the countries who participated and the geography. And we prepared this training with, in collaboration with the Department of Neonatology and Obstetrics and Gynecology. And really, you can see here the learning objective. We want to suggest proficiency in prenatal and neonatal consult, suggestion about the management of pregnancies when there is a fetal diagnosis of life-limiting condition, how to achieve comfort on those babies, and how to support those families. Here you can see some of the lead instructors beside me. other professors in obstetrics and gynecology and pediatrics and nursing school. By the way, following our training in 2019, we decided to assess the efficacy of the training course, and we obtained data from 88 attendees through anonymous survey, and the reported competence of the, we basically we gave them a test immediately before and then after the course, 1 to 3 weeks after the course. And the reported competence of the post-test was significantly higher in comparison with the pre-test for each item across discipline. So it was true for neonatologists, was true for neonatologists, was true for doctors and nurses. And we also wanted to study implementation over time, because you may be self-confident, but then do you put together a program where you are? Do you start doing perinatal palliative care? So in order to study that, 1 year after a training, we send another anonymous survey exactly to study this point. And here you can see on the left the quality indicators and the frequency data from participants' responses. And as you can see, there is a really high frequency of implementation, which led to the conclusion that attendance to the training increased clinicians' opportunity to translate perinatal palliative care into clinical settings. And speaking of which, here is the invitation for the 2023 training course, which will happen on September 20 to 22 in person here in New York City. In the past 2 years, we did via Zoom, virtual because of COVID, but this year we decided to come back in person. So, you know, I don't know if you are in the medical field, you personally, but I'll be happy to forward this invitation to colleagues, friends, or people that you think will be interested in that. And with this, I think I finish my presentation, and I am happy to answer your questions. Stop share.
Thank you so much. That was really great. And, you know, thank you even just for the really amazing work that you've done here. It's really, it's quite amazing to just see you go through those cases. Something we've been interested in as a team for a while. So thank you very much. I'm just going to share the questions now. So if anyone would like to kick off, you can either put a question in the chat, or you can just start speaking and I'll hopefully notice you.
I see Matt.
Julia, have you got a question there?
Sure. Go.
Oh, sorry.
Yes, I do, yes.
Go ahead.
Okay, so first of all, I just want to say thank you to Elvira. I feel quite blessed to be here, because I knew about your work. I've been knowing about your work for about the last 10 years, because I participated to the meeting of Rimini where you gave a talk there. And I actually went to that meeting particularly to hear your report and your witness about that. So I feel quite blessed. And thank you, Ilaria, for having added me a couple of years ago to the BIOS, because otherwise it would not have been possible. I've had a little question niggling in my head for the last week or so. I've recently come across the concept of moral distress in healthcare professionals. And my question was, have you noted, not sure if you have an idea what it is. There are various definitions of it, but I think it's quite obvious what it is. It's the incapacity to do what you really would like to do as a healthcare professional, where you think it's the right thing to do as a healthcare professional, but because of more internal or external constraints, you cannot really put to action what you think this is the right thing to do. And so it would be interesting, actually, as a research, to see whether the healthcare professional is involved in the care that you provide ever felt that in the last 15 years that you've been doing it. You may not have researched it, but you would have noticed it if people had started coming away from the palliative care, wanting to leave, wanting to a big sort of turnover of people and things like that. So what has been your experience so far?
Sure. So I'm not an expert. I can see moral distress in two categories. One, exactly the definition that you said, where, for example, you as a professional want to, let's say, produce a service for something like palliative care, for example, the way you want, but the structure doesn't allow you to do so, okay? Or moral distress because the emotional involvement is too high and you cannot take it anymore, And so for the second one, which is a question that I've been asked very often because, in a sense, being part of a palliative care team, we see 99.9% of the time babies dying and families in distress. The way we face this is in my team, having a team. So we support each other, we debrief the cases. So I had the luckiness to put together this team. So I hired the people that I wanted to hire. So they are nice and go along with me. They have my same vision, mission, and everything. And so we are becoming, we are definitely friends. We celebrate our birthdays. So we being together helps very much. Regarding the first part, meaning, if you would ask me in the early 2000s when I came to work here in my hospital and I saw there was such a need of a program like this, and if you had asked at that time, what do you do or can you do something, I probably would answer, there is not much you can do. I'm just trying my best as a doctor. And then things happened. I had my ideal within myself. And so in the beginning, I started following these women who wanted to continue their pregnancy, for example, with a fetal diagnosis, which was bad, to follow them. And even if I was not on service, I will go to the delivery. And even if I was not I had no direct care on the baby, I will help with the direct care of the baby. So I became involved. And then I saw a couple of nurses who loved what I was doing. And so they started volunteering with me. Then, in America, maybe it's easier than in England, we met some benefactors who gave us money. And so I could hire those nurses. So little by little, something happened. And we built now a program which is, we could do what we want in the sense of supporting the families, helping the baby, and use palliative care in the way that we think is safe and respectful of the life. So that's my own experience. And I think that, each one of us will do what we can. In the first few years, I never thought I could do something like this, and then it happened. Maybe for somebody else it would never happen, but they will be honestly doing what they can.
No, thank you. Because my question was in the context of the reason why. So I was a week ago, I was looking at the idea of moral distress for completely different reasons, and I came across the Kentucky project, which is this project about moral distress. And when I was listening to the various interviews that were explaining the project, a lot were intensive care neonatal nurses, and unfortunately, the main theme of these nurses was them having to face cases where the children were under intensive care for a long time, to the point of creating that distress. And in particular, one thing struck me is a nurse that said, at the time, I started questioning euthanasia, meaning I thought that probably euthanasia would have been a better option for this child. Now, hearing that reminded me of this conversation tonight. So it was a good reminder, because I wanted to ask you this question. And because the euthanasia was debated, I think, recently in the UK, I think for adults, not necessarily for children, but we do know that there's euthanasia available for children in some countries. And so that's why the fact that nurses say, oh, I never questioned it before, but I started questioning euthanasia because of what I've experienced. I wondered if you've come across one of your nurses or one of your doctors telling you something down those lines.
Sure. No, this is another face of the coin. So yes, I think because and especially I think in the United States, where medical techniques are so advanced, sometimes we go, because it's easy to keep going, even when your patient clearly is dying. And so, especially on the side of the nurses, this is very, it's terrible, because doctors, they order what to do and they go away, side 24/7. And so a lot of nurses experience this moral distress because they see this baby being tortured when everybody knows that eventually will die. And my point is, I don't think euthanasia is the right choice. I think palliative care is the right choice. So respecting the life, you can turn off a lot of machines which they don't give any benefit to the baby. They just give pain and suffering. And then you respect the natural life. The baby can live 1 day, 10 days, 1 month on his own. And so I think we need to, that's why we want to bring about all over the world our vision, because in a sense, we stand against euthanasia, because euthanasia is our own decision on the life of the person. And as a medical doctor, I am supposed to save life, to respect life, not to kill people. So, but palliative care is perfect, because if there is a baby who will die, the medical care doesn't improve the condition, you can make the baby comfortable and let them live wherever they can live. But thank you for the question, very good question.
Thank you.
I have a couple of questions. Thank you very much for your talk, first of all. And you mentioned the idea of quality of life. I mean, every time we hear these words, I mean, they are quite problematic. And I was wondering, what's your definition of quality of life? And this is my first question. The other is that, and maybe the other is related to this one, is about disagreements between doctors and parents. If it's something you have come across, and how do you deal with that? Because at some point you said, you talked about try to follow the parents' desire. I mean, it's I don't know very well in US, but here in particular, when there are disagreements and then parents' desire at stake, you know, the right balance, I mean, find the right balance becomes very tricky. And my last question is about, do you think that this program can be applied to younger children? I mean, not only babies, newborn babies, but very young children with disease, either incompatible with life or without any cure. Okay, thank you very much.
Starting with the third question, yes, absolutely. In fact, perinatal palliative care is born out of palliative care. So, and it can be, what I do can be applied with small children, adults, and old people. It's just the fact that when you have a medical judgment that there is a life-limiting condition, you know, I don't like the expression incompatible with life, because and everybody's alive, even a baby who is born first day of life, because he lived or she lived during the pregnancy. So life is there, it's just short, no? And so the principle to be taken care properly, to be on comfort, to be fed somehow, etc., to be free from pain, it can be done at any age. And this is the alternative to euthanasia even, no? Second, the second question about disagreement from the parents, it happens, I want to say almost all the time. Why? Because mommies in general are very defensive. They want to not for the, at least in my experience, most mommy, they don't want the baby to suffer. And so it's easy for them to accept comfort care, for example. Fathers are always, we need to do something, we need to do something. That's their role. No, they are the head of the family, they need to fight for their children. And so very often it's difficult. Obviously, we need to talk. We need to have a social worker or psychologist involved. We actually, sometimes I tell them, do you have anybody in your family that you trust, a friend, a religious leader, or someone else that you want to discuss the issue with them? And you try your best. I don't think there is an easy solution. In extreme cases, I think you can call like the ethic committee to help, but I probably never went that way. We always try, with what we can to come to a solution that is good for them. So there is no easy solution. Okay, we need to give time, and try to understand why they stand, how they stand. And the first question was about, I forgot, quality of life. So quality of life is, I don't like that expression, to tell the truth, because it can be used in many wrong ways, but let's use for what it is. So life is a given, and on a life, we want to have quality. Quality means being comfortable, for a baby or for an adult or for an old person, anybody who has a life-limiting condition, so a condition that is not curable. From now to the moment of the end, we want that life to be the best possible. Okay, that's my definition of quality of life. And I think that the pillar that I use for quality of life, for comfort for my babies, can be used also for people of old age, because to bond with the family, to be surrounded with someone who loves you, to be, I don't know, to be fed in the sense to receive some food that you like, or to be in an environment with nice and clean and not to suffer pain, that's quality of life for me. So to achieve a situation where we feel comfortable, and for an adult, a person who can, can think, can ask questions, also a psychological comfortable environment. With the babies, I think sometimes it's easy because they're not aware. They're here at this moment. They are not aware they are dying, for example. So all this anxiety we have as adults, they don't have it. And so much easier. But yeah, so that's my definition. Yeah. Any other question or comment?
Just going on from that, actually, relatedly, I was just very quickly scanning down where you did the definition, and you did the survey to parents to measure their levels of comfort. So in your first published paper. So yeah, I was wondering as well how you just defined comfort, and how you defined, because here there's really a mix. There's a mix between comfort to the parents and the parents' perception of the baby's comfort. So those two things are sort of linked sometimes, obviously, because if the parent feels the baby is comfortable, that's very comforting to them. But yeah, so I just wondered if you had any sort of guiding principle, or you were just, or really this was just more of taking things from kind of the experiences of nurses as useful metrics. And then I wondered, maybe more specifically, you could say something about, I noticed that one metric was quite low, which was the ability to feed. That was the one that had the lowest measures. I take it that's because many of the babies aren't well enough for that. So yeah, just wondered if you could say, so for example, there was a lot of stuff about, is my baby in a quiet, nice environment? How does that sort of relate or how is that put together in the same category as like, can I feed my baby?
So no, thank you for mentioning that. So there is a rule in neonatologists that is happy baby, mommy is happy. This is true even in the nursery, no? So when the baby is happy, mommy is happy. I strongly believe that the comfort of the baby and the comfort of the family, they go along. And so the question that we ask in that paper were, was your baby warm? Was your baby sleeping? Was the environment, there was too much light, too much noise? Will you be able to change the diaper of your baby? So we ask a specific question regarding how, or do professional care for your baby? Or do you think your baby was welcomed by the professionals? I don't remember exactly, you know, but I'm telling you the sense of those questions. And we have also questions like, will you be able to feed your baby? And we realized that, for example, in feeding, the number were very low. Well, because almost all these babies died within the first 24, 48 hours. And so imagine a baby who is born is comatose, you can feed the baby because the baby is dying. And so number one. Number two, mothers who underwent C-section cannot physically feed the baby. And so that was a question was a little bit tricky because it did not correlate with actually the positive experience of the families who came out from many other questions. But in our experience, because also of other studies that we did later on, and then, you know, the day in, day out experience with families, what impresses me is that families always thank us so much. They send letters, they send a lot of gifts. So part of the financial support of my program is out of philanthropy, who comes sometimes from parents. And so I always wonder how come that while my goal is to save baby's life, I receive thankful letters and even financial support by parents whose baby died. This gives you an idea of the appreciation. We just had a little baby in our NICU who died last week with basically a very rare cancer. And at a certain point, after a lot of treatment with oncologists, realized that there was no other way to go because even the side effect of the medication, they were killing the baby. And so we redirect care. And so what we did, we took off all, you know, lines, tubes, everything. We dressed the baby as a baby, and we let the parents in a room with their baby for 24 hours. I mean, we were going back and forth in and out. But basically, they stayed with the baby, they give a little bottle. Then at a certain point, they went out. We have a nice backyard in our hospital. They went down to get a little sun. They took pictures. And just today, they sent us a message. You allowed us to have a day with our baby, like we and the baby was comfortable. He had only one line running a morphine drip in a doses that was not killing the baby, was keep the baby comfortable. He was awake with open eyes. And so that's the comfort and the, you know, the comfort of the baby and the comfort of the family that we are looking for. Yeah.
Thanks, that's really brilliant. Any other comments or questions?
If not, I'm good to go. I have like 20 messages from that baby that I left in the living room. So better for me to go back and see that family. But thank you for your attention. Thank you for your questions. And by the way, feel free to put in contact with me anybody in the obstetric or neonatology world, nurses, doctors, whoever wants to participate to our training, I'll be happy to send invitation.
Absolutely. Well, we'll let you get back to the actual work that you've told us about. That's definitely better than staying chatting to us, but we're very glad that you did come and give us some of your very valuable time. So thank you so much. And I'll see many of you next month for the next BioCentre talk. Thank you very much.
Bye-bye.
Thank you. Bye. Bye-bye. Thanks.
Thank you.